Now, ladies and gentlemen, we move on to a significant and honored tradition of Sri Lanka Medical Association, Sir Marcus Fernando Oration 2025. So this memorial oration commemorates the remarkable legacy Sir Marcus Fernando, a pioneer in Sri Lankan medicine whose contribution has left an enduring impact on clinical practice and medical education in our country. Ladies and gentlemen, the procession of the Sir Marcus Fernando Oration 2025 will start shortly. Ladies and gentlemen, I kindly request you to rise from your seats for the arrival of the Sergeant-at-Arms carrying the ceremonial mace into the premises with the orator of Sir Marcus Fernando Oration, accompanied by the procession led by the President of Sri Lanka Medical Association. Ladies and gentlemen, you may now be seated. Dr. Surantha Pereira, the President of the Sri Lanka Medical Association, will now read the citation for the orator, Professor Athula Sumathipala, who will be giving his oration on No Health Without Mental Health, 25 years of research evidence into impactful actions for people's benefit, and he will be presenting him with the orator's medal.
Deputy Minister of Health, Dr. Hansaka Vijayamuni, Professor Krishanta Abesena, Minister of Science and Technology, Chairperson and members of the Board of Trustees of the Sri Lanka Medical Association, past presidents, members of the Council, honorary line members of the SLMA, and distinguished invitees. It is indeed a pleasure and a singular privilege to present Professor Athula Sumathipala, Emeritus Professor of Psychiatry, School of Medicine and Health Science, Keele University, UK, as the presenter of the Sir Marcus Fernando Oration. Professor Athula Sumathipala is a distinguished physician, academic and researcher who has dedicated his career to improving mental health and advancing medical understanding across Sri Lanka and global community. He received his early education in Anuradhapura, Hambantota and Matara, then entered the Faculty of Medicine at the University of Colombo from Nalanda College. After graduating an MBBS, he specialized initially in family medicine, obtaining a DFM and MD family medicine, and became a board certified in 1991. He later trained in the United Kingdom, where he completed MRCP Psychiatry and specialist training in psychiatry, followed by a PhD from King's College London. He also a fellow of the Royal College of Psychiatrists, UK, and an honorary fellow of the College of General Practitioners of Sri Lanka. Professor Sumathipala has served on the Council of the Sri Lanka Medical Association across multiple terms and has held leadership roles in academic research and national scientific institution. He is the current co-editor of the esteemed Ceylon Medical Journal. He has served as chairman of the National Institute of Fundamental Studies and currently holds senior academic positions, including Emeritus Professor of Psychiatry at Keele University, UK, and Emeritus Professor of Global Mental Health at King's College London. He has also led and strengthened the Institute for Research and Development, IRD, in Sri Lanka for over 2 decades. His research concentrates on the connection between physical and mental health, medically unexplained symptoms, suicide prevention, ethics in research, mental health during disasters and displacement, and capacity building in low-resource settings. He has over 150 peer-reviewed publications, authored 16 book chapters, published 4 books, and obtained more than 25 international research grants from leading global scientific organizations, including the Wellcome Trust, Medical Research Council UK, WHO, and the World Bank. He is also the only Sri Lankan to serve as Associate Editor of the British Journal of Psychiatry since its founding in 1853. He has contributed to several WHO expert groups, including those focused on suicide prevention, mental health policy, and the classification of mental health conditions within the ICD system. Professor Sumathipala has received several national and international honors, including the H.B. Williams Travelling Professorship from Royal Australian and New Zealand College of Psychiatrists, where he was the first and only Sri Lankan recipient. He has also been awarded SLMA CNAPT Award for the best publication twice, multiple President Awards for scientific research, and the National Science Foundation Award for outstanding leadership in science and technology. He has delivered several prestigious orations, including the SLMA Sir Marcus Fernando Oration, the NDW Lionel Memorial Oration, and the SLMA Oration 2025. Alongside his academic work, he is also recognized for his contribution to the arts as a lyricist, including the well-known song Bedi Sitiati, sung by Amarasiri Piris. Professor Athula Sumathipala, sir, I am sure that this esteemed audience would join me in sincerely congratulating you on all your achievements. The Sri Lanka Medical Association is immensely proud of you. As the President of SLMA, I am honored to award you the Medal of Honor at the Sir Marcus Fernando Oration of 2025. I also warmly invite you to deliver the said oration now.
Dr. Surantapera, thank you very much for that generous introduction. Honorable Minister of Science and Technology, Professor Krishanta Besena, Honorable Deputy Minister of Health, Dr. Vijay, Honorable Member of the Parliament, Dr. Nihala Besinga, Secretary to the Ministry of Science and Technology, Mr. Nawavi, and there are a lot of officials from the Ministry of Health. My dear teachers, colleagues, council members, past presidents, I do consider this as a privilege and honor, but more than that, I consider this as a great opportunity to share our work as titled For Policy Impact for People's Benefit. I'm also grateful to all parliamentarians being here in spite of having the budget speech, and that really shows how much serious you are about making our nation a different turn from the opportunity you all have received. Sir Marcus Fernando, is traditional to briefly mention about Sir Marcus Fernando. He was born in 1864 at the age of 19. He entered the University College London, being the first student from Ceylon to study medicine there. He qualified in 1888 with MB, obtaining the gold medal for medicine and forensic medicine. In 1889, he obtained his MD and was made a fellow of the University College in 1890, the first Ceylon graduate to be so honored. In 1891, he returned to Ceylon and joined the government services. He was the second physician to be appointed to the Colombo General Hospital and was the first Ceylon doctor to hold the post of registrar to the medical college. At the age of 34, he was appointed senior physician to the Colombo General Hospital as lecturer in medicine. Dr. Marcus Fernando was the secretary of Ceylon branch of the Medical Association 1891 to 1897 and became the president in 1905, being re-elected for the second term. At the age of 45, having reached the peak of his chosen profession and resigned from the government medical services and devoted a major part of his greater energies to his many varied interests, including agriculture, economics, and politics. In 1921, he became a member of the Legislative Council and was appointed a member of the Executive Council. He received a knighthood in 1923, and sadly at the age of 71, on the 18th of December 1953 in London, Sir Marcus Fernando departed from this world. Sir Marcus Fernando Oration was started in 1969 and I was fortunate to deliver this oration months before. So traditionally, the orations are delivered in imprint format, introduction, method, results, and discussions, with a lot of statistical jargons, but it's boring. I'm not going to read a script. I'm going to tell you a story, like before, a narrative. Why? Because today, I think it's an unprecedented gathering of leaders, political leaders, policy leaders, academics, printed and electronic media personnel, professional organizations, and most importantly, informed public and service users, people with lived experience in one single room. So my focus is going to be on knowledge mobilization. That is actively taking the knowledge where it is needed rather than having just scientific discussion in closed doors. The purpose is to accelerate the impact of the research we have done. Focus beyond academic impact, beyond us, beyond me, beyond what we receive, the graduations, promotions, citations, conference travel. So really mean a culture shift, research for people's benefit. Beyond us, why? We receive public education, we receive public funding, and we carry the public knowledge further. And we are accountable. It's not only the politicians who are accountable for their responsibilities. We are paid by the taxpayers' money. We were educated, so we have a duty and responsibility to pay it back. Expanding the impact of academic research beyond academia is known as implementation sciences. Implementation science is the scientific study of methods and strategies that facilitate the uptake of evidence-based practice and research into regular use by practitioners and policymakers, as the President alluded to. It aims to increase the adoption, implementation, and maintenance of evidence-based interventions in real-world settings to improve individual and population health. This field focuses on integrating recent evidence-based ideas, practices, and policy into various settings such as communities, hospitals, and clinics. Assessment, dissemination, adoption, implementation, I'm going to talk about it later. So research for implementation, it takes on average 17 years to make research into policy. But this particular paper discusses how implementation sciences seeks to narrow the often years of long gaps between development of evidence-based practices and their routine use in real world. So I'm trying to make this a third eye awakening, reflecting on the local evidence base, and particularly would like to talk about the barriers and facilitators to translating research into policy and practice for nation's benefit. They include individual characteristics, rather stereotypes. It's not my prejudice, and the system or organization factors. There's a systematic review I'm going to quote next. So there's plenty of evidence throughout the world, particularly in our part of the world, that these characters would affect negatively for implementation of research into policy and practice. And therefore, breaking barriers has to be through evidence-based medicine. Breaking barriers to facilitate translating research into policy and practice is a must. So this is the systematic review I mentioned. And in the discussion it says, findings highlight the urgent need to institutionalize scientific evidence in policy formulation through formal governance frameworks, sustained stakeholder engagement, and robust science policy interface. Advancing transparent, Inclusive and evidence-based governance will require cross-sector collaborations, epistemic trust, and particularly the political leadership committed to bridging the gap between research and public policy. Honorable Minister, your vision for ethics, governance, and research integrity will play a crucial role, and you have appointed a committee, and I really sincerely thank you for trusting me and appointing me to be the chairman of this committee. And we have formed that committee. There are 5 medics and 10 non-medical people. We are talking about ethics beyond integrity and governance beyond medical fraternity. You saw the minister showed a lot of institutions. So here we are talking about beyond human subject research, beyond animal research, but research using big data and beyond that. So therefore, on the 13th of this month, to mark the Science Week, we have organized this. You would say there are eminent medical experts who have plenty of ethical experience coming in as resource people, but there's one person, Professor Vijay Sundara, from agriculture background. So we extend to expand all these. And also, on the 11th, before that, we will be organizing another workshop through the Ministry of Health, the full day on research ethics and community engagement and involvement. That is the power of branding. At the IRD 25 years of research, we have always had ethics and community involvement and engagement as strong pillars, with capacity building on the top and global health collaborations. And this is published, you can read. Quite a lot of experience cited there, and this is evidence-based. So in this context, the oration is based on 25 years of work we have collectively done at the IRD. Although I'm delivering this oration, it's not my oration, it's our oration. It's collective work. So data will be presented from epidemiological and intervention research on suicide and life-threatening behaviors, disaster-related research, awareness raising and policy impact work carried out after tsunami on resilience, island-wide mental health prevalence survey, community and school-based, research on mental health consequences of forced migration from north to northwestern province, Middle East migration and psychological impact of left-behind families, research on care burden on dementia patients in Colombo district, child and adolescent mental health post-war research carried out in northern province, research awareness raising and policy impact on service development and maternal depression in Colombo and Anuradhapura. This is the most important piece of work. I'm going to concentrate more. So therefore, I'm not going to deal in depth with the other projects. And also first episode of psychosis currently going on in southern province, and I want to talk a little bit about stigma related to mental illness as well. So this work has been presented before, so I'm not going to cite any of those, but it includes some of the work cited there. So these are some of the things which we have presented, the findings from our part of the world, evidence, for knowledge mobilization. To name a few. So, no health without mental health. Dr. Brooke Chisholm, the first Director General of Health Organization, was a psychiatrist and spearheaded the notion that mental and physical health were intimately linked. He famously stated that without mental health, there can be no true physical health. A half a century later, we have strong evidence in elucidating the bidirectional relationship between mental illnesses, specifically depression and anxiety, and physical health. However, policy continues to lag behind the evidence demonstrated by global non-communicable diseases. Last year, the Director General, addressing a diverse and passionate group which included government representatives, mental health experts, advocates, and especially those with lived experience on mental health, reiterated that we are all united by a common mission to improve mental health around the world. mental health is one of the most neglected areas of health. I would like to say that there is no health without mental health, unquote. Yet, many countries devoted few resources to providing quality mental health services at all income levels. This is often compounded by the stigma associated with mental health, brain health, and substance use conditions, which is often barrier to care for those needed. Ironically, even today, there is a serious mental health divide between the global north and the global south, which is stark and multifaceted. Health outcomes, resources, access to health care, and nature of disease. However, on a very positive note, I am delighted to note that the recently published draft, Transforming Health for Sri Lanka, the National Health Policy has recognized mental health as a key component. Congratulations. And it has got two pragmatic areas. I'm pretty sure the director policy, India is here somewhere. Key programmatic areas and cross-cutting themes. So my talk is actually aligned with what is in the National Health Policy. Some of the previous orations we delivered, we have presented those, and today I'm going to cover some of these highlighted in yellow. And also, pleased to note that, as again, the Deputy Minister mentioned about integrating primary health care. I'm a primary care physician, and the government plan is to, also Honorable Minister Science and Technology spoke about it, and the plan for setting up primary health care centers. This is the way forward for our nations. Once again, thank you very much for picking up all these and aligning the policies along those. However, the global context is pretty bleak. That's what we call the north-south divide. You name it, expenditure for health, research funding. In this backdrop, laying foundations, all these colleagues are here. 25 years ago, started as Forum for Research and Development, which evolved into this institution right now. So we wanted to actually examine the ground reality, where we stand. 25 years ago, we surveyed 5 leading journals of mental health over 3 years to find only 6% of research come from 90% of the world. And later, 11 journals were surveyed, still it has gone only up to 12%. And we surveyed, mapped the research capacity in our part of the world, and it's significantly low. It's not only for mental health, even medical journals you all read carries only 6.5% from 90% of the world. We repeated the survey, it has gone from 6.5 to 12. Evidence-based medicine, are we practicing? Or is it evidence-biased medicine? Whose evidence is that anyway? The criticism is about evidence-biased medicine, so the way forward is, the solution is for evidence-based medicine, local evidence-based medicine. And therefore, over the last 25 years, we have carried, you can see, we have taken ethical clearance from almost all the universities here. And when we do collaborative projects from the universities abroad. The first longitudinal research program was about suicide and life-threatening behaviors. We all know that we had higher suicide rate in the past. And when I talk about any of the work we do, we duly recognize the work that had been done before, particularly in 90s to reduce the suicide rate. Professor Saroj Jayasinghe here, I think there was a national commission appointed by the president at that time. There were a lot of positive public health measures taken, decriminalizing suicide, and also access to pesticides, also other research groups like Professor Edelston, Professor Nimal Seranayaka. However, there was many research gaps in understanding the suicide process and intervention at individual levels. Therefore, a prioritized research program was established at the IRD about suicide. And you all know who he is. He led that. And one of our strategies was, with all this research, we have always produce next generation research leaders who will grow taller than us, and he is one of them. To complete a suicide attempt, it should start with suicidal ideation. Suicidal ideation can lead to attempt and complete suicide. No study has looked at the prevalence of suicidal ideations in general population in Sri Lanka before we did that. So Sudat, for his MD in Ratnapura district, did that, looked into the prevalence of suicidal ideations. The study was carried out in 6 out of 17 divisional secretariat, 880 random sample. We used Beck suicide ideation scale, and 4% had active suicidal ideas and 3% passive. In terms of real numbers, huge. Remember, people do not volunteer suicidal ideations unless they are asked for. So therefore, we further investigated this. I was his supervisor for his MD and PhD both. We did what we call the psychological autopsy study and found that more than 50%, and those who know about qualitative work, the numbers doesn't matter, it's the saturation of information. So 50% of people who completed suicide or attempted reported that they had a history in the family and also a family history of mental illness, and 25% actually had a previous attempt. So it may be genetic, it may be modeling, but the implication was that we could use those as high-risk people for outreach approach for suicide prevention. In the island-wide mental health survey, we found that people felt that it's no point in living anymore. Once in lifetime, many will have. Then some felt like dying is better than living. However, thoughting of committing suicide was 5% lifetime and 1.6 over the previous week. So it's extrapolating from the current population, 5% is over 100,000. 1% is over 600,000, 5%, 1% is over 100,000. Quite a lot in terms of true numbers. So from epidemiology to intervention, based on our previous work on cognitive behavior therapy, Sudat did his PhD study and randomized control trial. So the potential impact pathways of that work on suicide can contribute, particularly because mental health upward suicidal trends had been highlighted as one of the things in the policy. So we had suicide prevention South Asian policy. Both Sudat, myself and Nihal was WHO advisor at that time, were there, and we are still together. We will continue to play our roles collectively. The National Mental Health Survey, the IRD carried out a sample of 10,000 only for just $30,000. It was a meticulously planned. This is just to convince you that the planning, clustering of samples, a lot of work went into this. Training, hundreds of research assistants trained. To maintain the quality was challenging. Teachers were trained to do the school survey, and data collection was very challenging. You can see the ways they had to travel into the peripheral parts of the country. Unfortunately, North and East, we couldn't do it because of the war. So these are the findings. Overall prevalence, close to 12%. Major depression, 2.5. Moderate to mild, 6.7. Somatoform disorders, that is medically unexplained symptoms, and anxiety disorders and post-traumatic stress disorder, relatively low. Good. And the Putlam had the highest percentage, 20%. The policy impact was a consultant psychiatrist was appointed immediately after the survey. And the other good news, demolishing the myth of PTSD. Western pundits after tsunami was saying Sri Lankan PTSD would be 60%, 70%. But we are a resilient nation, and it was quite low. Then we went and did quite a lot of qualitative work to try and find why it's so. We also had a psychosis component. I'm not going to go into details. And these were the findings and dissemination. We did the school surveys, large samples once again, covering the schools, primary schools, and other 3 types of junior schools. Things were published. I'm not going to go into details, but this shows, using strength and difficulty questionnaires, even children admitted having emotional conduct, hyperactivity, and peer problems. But you would see the teachers' rating and parents' rating were rather high. So there is an issue with our system. We did mental health literacy survey and attitude survey. Again, I can't go into details, but 2 important things which transpired was stigma and impact of stigma. We did quite a lot of work globally as well. You can see 35 countries qualitative work. There's huge discrimination at the workplace among individuals with major depression. So based on all this, the WHO commissioned us to publish this manual. We did quite a lot of training. But my message is, it's very easy to understand the mental health signs and symptoms. It's normal. We all feel sad, feel frightened. All these are normal. But at one point, it can disproportionately increase or qualitatively change. A pregnant mom who should be happy becomes unhappy. Mood changes. That's something, a clue to understand. So it's a very easy to understand either quantitative or qualitative variation of normal human traits, feelings, behaviors. That's signs of mental health. So that's the approach strategically we took in our educational material and still doing, making recognition very simple. Then we extended our research programs of complex emergencies and resilience, again developing research leaders. Unfortunately, Chesmal died untimely death. We did quite a lot of work in southern province, and the finding was Sri Lankan people cope by investing on religious faith. That is where the resilience comes from, whether you are a Buddhist, Hindu, Muslim, or Catholic. So that explains, that's why the local evidence is very, very important, local data. Then we went ahead and did internal and external migration studies, once again led by Chesmal. We studied Muslim population who was displaced in 1990 from northern province. There were 15,000 families, 65,000 individuals resettled in Putlam district. 2 cohorts were studies, initial cohort and the follow-up cohort, and a lot of qualitative work was done. So it showed, you can see, the overall prevalence was very much higher than the national prevalence. Medically unexplained symptoms was disproportionately high. That's a very important morbidity I'm not going to talk about. I gave a separate oration on that. That cost a lot, Honorable Minister, for the health services. And depression, major depression, national average was 2. There it was double. We did the follow-up study again, but fortunately, by then, the morbidity has decreased. Why? So these were some of the papers we published. All this was shared, but the reason for reduction was we did some work on training primary care physicians and doing intervention studies, and that helped, in the makeshift camps and in those areas the interventions were done. Then we also contributed to the external migration left behind family spouse study commissioned by the ministry. That was one of the 4 projects contributed to the national migration policy. And Dr. Susipera, I'm sure she's in the audience, she led that time, the whole thing. And our component was this. Once again, we published. I mean, I'm reiterating, you should do research and share the findings. and this had a national impact for migration policy. These were published. We also looked into the economic aspects of labor migration. Then we took these studies to North Province, Vaunia, again 2 research leaders, currently both of them are reading for their PhDs. And during that project, for 1 year, we developed capacity within the Ministry of Health. You all doctors get a 40% research allowance. So through Kiel University, supported by Dr. Sunil Dialvis, we carried out all 1 year, and there were 10 projects developed, and we actually funded one. That was the Vaunia project. Then we have done quite a lot of work into dementia. Kalpani Abesing, who was the head of the Allied Sciences Nursing Faculty Department at KDU, did a free PhD with me at Kiel, again, leadership development, but her studies was in Kaduwela district, looking at carers' burden. How do informal carers describe the meaning of caring for a person? What are the challenges? And so on. We did quite a lot of community involvement work as well as a part of it. Now, this is the most important component I want to concentrate on in the rest of the time I have got. Research program on maternal mental health. It's a grand challenge, integrating maternal mental health into maternal and child health programs, led by Atif Rahman, my friend, colleague, worked for 25 years. Perinatal depression, 1 in 10 pregnancies in high-income countries, but it's 1 in 5% in our part of the world. Maternal mental health, the missing M in the global mental and child health agenda. Now this is, I'm just not going to go into details, and cost of perinatal mental health is very important. Last week I was at London School of Economics discussing with my colleague Annette, and it's very crucial to assess the economic impact of this morbidity, particularly our part of the world, even in Sri Lanka. And as you know, 1 in 5 depression and also maternal suicide is one of the leading causes during that period. Don't get me wrong at all. We have excellent health service. When they are detected, they are managed by psychiatrists. All that is there. However, the challenge is, they are not being detected in advance. So, costing, again, our colleague has developed this model. It will be available very soon, and we are going to do the costing for Sri Lankan as well. Then there was quite a lot of epidemiological work done by others, Sunetta Gampodi's team, Rajarata cohorts. There's clear evidence that it's a big burden. Predictors and occurrence of antenatal depressive symptoms in Gaul, mixed method studies, help-seeking intervention for depression and suicide in Sri Lanka. There's a lot of epidemiological work, but the issue is taking epidemiology to interventions. Improving access to psychosocial interventions for perinatal depression in low and middle income countries. Atif Rahman led that. Efficacy of culturally adapted cognitive behavior therapy based intervention for postnatal depression in British, South Asian, multi-center randomized controlled trial. Task shifting is happening in Britain. That's the message I want to take. Therefore, particularly when we don't have adequate resources, task shifting, the word is frightening for some, I know that. Let's call it task sharing. It's not trying to take away somebody's responsibility or the territory, but training people, primary care physicians, midwives, to detect perinatal depression well in advance. And then, if they can manage, they manage it. If not, they refer. Integrating WHO Thinking Healthy program for maternal mental health is happening in China. This maternal Thinking Healthy program was developed by Atif Rahman, tested in Pakistan with overwhelming evidence of efficacy. WHO adapted it, and based on that, funded by the US NIMH, we had this hub. Dr. Nihala Besinga was part of it. And we started this grand challenge integrating maternal mental health into health programs in 2013. You can see some of the health secretaries, additional secretaries. It was a long overdue thing. Fortunately, later we got funding from NIHR to do it in 4 countries, scaling up the perinatal depression through technological advancement using Thinking Healthy program. Honorable Minister was talking about it using technology. Bangladesh did that, but Sri Lankan study was different. We had this enhanced meeting in 2004 in Lahore. We met regularly, we meet regularly. And in Sri Lanka, we did a lot of community and stakeholder engagement involvement. And this particular manual was adapted, not just translated and back translated. We adapted, you can see from the pictures. Even the drawings were changed for cultural adaptation. And this is the young lady who is leading that project. Just completed a PhD, Krishani. Rajarata graduate with a first class health promotion. And in her methodology, I'm going to finish soon, a qualitative study to explore perspectives of stakeholders on facilitators and barriers for implementation of task-shifted Thinking Healthy program to treat perinatal depression in Sri Lanka. Qualitative in-depth interviews were done, focus groups were done, and exploration, preparation, implementation, sustainment framework was used to guide the study. It's a lot of jargon. I'm not going to go into details. Exploration, preparation, implementation, sustainment is the framework, and it was done in Colombo and Rajarata. Now, this is, I'm going to say, for those who are not very familiar with qualitative work, might think, what is this, 81 people? In terms of numbers, no, this is a very, very rich data set. Krishani and our team spoke to doctors, nurses, 12 in-depth interviews, taking hours and hours, PHMs, health administrators and technical consultants in the Ministry of Health, women with lived experience, women without lived experience, and enhanced team, and trade unions through Dr. Nihala Besinga's suggestion, because overwhelming finding was that the public health midwife is the best person to detect this morbidity well in advance. So we were worried at one point, what would be the trade unions say? They liked it because the whole message was that they see it, they don't know how to do it, they don't have the skill set. We want training, we are happy to do, yes. We are going to be overstretched, we will be burdened, but that's something for the politicians to decide in terms of numbers if they want to address this. So the data analysis framework analysis method was used. The framework analysis is again a bit of a complicated thing. Krishan is an expert on that now. For the analysis, a priori framework was used, which I mentioned. Based on the outcome of framework analysis, barriers and facilitators were identified. Again, it's a lot of things to discuss. We can't discuss in a room like this, but the analysis was societal, family factors. One of the main things was lack of awareness about postnatal depression, stigma, client characteristics, healthcare systems, systemic gaps, system resistance, managerial and accountability issues, issues in financing, organizational factors, provider characteristics, intervention characteristics, and trade union characteristics. So this, believe me, we are prepared to discuss with all the relevant people, taking time, going more in details into these things, which is very, very important and crucial. The key findings of facilitators, again, societal and community factors, cultural, compassion, reduce stigma, how to do it, healthcare system. We have a very good, well-established health system, policy is supportive, stakeholder buying-in is there, ministry welcome collaborations, acceptability of the MOH staff, buying in current services for perinatal depression exists. So putting all this together, intervention fit, and there's a lot we can move into. Again, based on all this analysis, implementation strategy for integrating was developed. Again, this is too complicated to discuss it, but I want to reassure you, there's a lot of substance in all these research frameworks we have done. Again, we have published these, and we produced a teledrama half an hour. I wrote the theme song, but for both these, we did extensive amount of consultations, even the script, public consultations, service users, and this teledrama educational within 1 month was watched by 100,000 people. This was the consultation meetings. These were the feedbacks people gave. And we took it to pregnant mothers, lot of consultations, feedback, KDU. Even the teledrama, before releasing, you can see some of the known faces of your colleagues here. Extensive consultations, even for the teledrama. And we released that. We also presented a special session during the International Congress of Twin Studies where 32 countries participated. Honorable Minister was the chief guest. And there were service users participating and discussing about their experience. And the ETR, Ministry of Health, invited us to raise the awareness among trainee midwives, which we did. You can see from the pictures, and you can see from these graphs, these are their feedbacks of the value of that training and helpfulness. So we had discussions with WHO Colombo office, developing this advocacy brief. So that's that part of the thing. So I very much would like the policy support to take this further. Very briefly, the psychosis study is happening in Gaul. Team is here, some of the colleagues, led by Rumi Ruben, NIHR grant. We have a lot of policy support. The importance is this: people, if undetected, having psychosis, die 10 years prematurely. And I want to highlight this slide. This is actually borrowed from Asir Hewamalage. Community engagement throughout the research cycle in formulating questions, designing the project, carrying out the project analysis, and presenting them. They have a due role. The last few slides, benefit of stakeholder engagement. If you engage the stakeholders, as the Honorable Minister said right at the beginning, improved decision making, improved communication, increased understanding and buying in, great understanding and support. So implementation strategy, the missing link is stakeholder engagement. That should happen through and throughout the cycle, including economic analysis and cost effectiveness, which I mentioned. And the stakeholders, wider public, policy and politicians. That's why I'm so glad under this roof today, all of them are here. When it comes to stakeholders in mental health, we know the Central Ministerial Office has all these, Family Health Bureau, ETR, but we also have these sectors in the periphery, and most importantly, people's voice matters, researching with lived experience. To add to that, supporting career development, not only of IRD colleagues, we are supporting the ministry. These were some of the post-MD colleagues, but this is the message here. We are supporting to develop research supportive medical administrators training. There is a team under training right now, and these 3 people who are in the audience are going to go next year. Why? we need administrators who are research supporting and sensitive to converting evidence into policy and practice. Stakeholder engagement is a must. So it's time to think, repositioning the agenda on the overall research impact beyond academic impact. Our mission, unhesitant and unrepentant, will be that. Will you take that challenge? Everyone in this room, Zoom or otherwise. That's my plea to you. We need your support. This is not just one-off. Our advocacy campaign will be continued through and throughout after this oration as well. Finally, for all this hard work, we got national recognition, which is important. We are very humble about it. And our story will be very soon printed in a coffee table book, the hard journey we went through, the strong collaborations locally, regionally, and internationally we have. And Honourable Minister, you have seen this slide before, we have brought in millions of pounds, not rupees, to this country for research, which is a big scarcity, right? And research-wise, the impact, you can be proud. We have taken local evidence globally. Institution building, we started with this single dilapidated ancestral home room of my wife. We are here now. It's teamwork. It's nothing but teamwork. History and evidence of good teamwork. You saw the output, collaborative ability, and members' individual development. So, where should we go from here? Start thinking. Think about impact beyond academic impact. This article I wrote 5 years ago. Now, history has given us a good opportunity, a land, unprecedented opportunity. Recently, the cabinet allocated 250 million for mental health promotion. Straight away, we wrote to the Secretary Health, who is very supportive, offering our services. Elderly population, demographic transition, again, the government is investing a lot. So, it's time for a long overdue shout out. I think we need island-wide mental health survey, including elderly survey, because our survey was 2007. Figures have changed. Without figures, you can't plan. What do we want? To ministers, we want only statutory support. Recognition as a respectful and valued partner, and offering collaborative support. If you give that, the culture shift to research for people's benefit, we can serve more for our nations. We guarantee quality and satisfaction. Finally, acknowledgements. This was our original executive committee. Most of the faces you know. When we started from scratch, none of them took a salary. All these were voluntary work. On and off for very patchy periods. For projects, we have claimed a nominal fee, but not most of them. This is our current executive committee. We have a research council led by Asiri Hewamalage. So we have full-time, part-time colleagues in other institutions. And we have a very limited staff, but strong collaborations. And finally, I want to thank my late father and mother for supporting me, guiding me with all this work. And this slide most of you have seen. With my research with IRD, these young girls grew into professionals. And I'm very grateful to them. and to Vijita, a big thank you. Finally, I would like to thank the Oration Committee led by Dr. Sachit Mettananda for giving us this opportunity, and SLMA President and the Council for giving this opportunity to try and share some thoughts may be provocative, because I know one of the people asked me, why do we want politicians in this room? That person is in this audience and he will know why we want politicians. We can't have science for people's benefit, research for people's benefit in closed doors and intellectual stimulating debates and discussions. It's a commitment as a nation we have to do. So I have shared our collective thoughts, what we strongly believe. Please support us, work with us. We by no means undermine the good work, contributions made by other people. It's not only us, it's a collective thing. I assure all the ministerial employees, leaders, we would like to come and talk to you, spend time, share these things, discuss, but let's work together for nation's benefit. Thank you very much.
Thank you, Prof Athula Sumathipala, for that eye-opening oration. So we would like to congratulate you on this occasion. Ladies and gentlemen, we have now reached the end of the proceedings. So thank you for being with us at Sir Marcus Fernando Oration 2025. And all of you are kindly invited to the tea outside hall and before we reconvene for the Parallel Symposia. So may I now please request you to please rise from your seats as the ceremonial maze is being carried out of the hall.